on the CB1 and CB2 receptors. A couple of particular points. So CB1 we think as distributed primarily in the central nervous system, and CB2 is more of a peripheral receptor, but it actually is present in almost every cell of our body, at least one of those receptors, if not both. And most of the CB2 responsible for immune system modulation and also to some metabolic functions like a bone, cardiac, and GI. A word on an actual CB1 receptor impact on the central nervous system. The key word to memorize is this blocking of neuroexcitation. So the CB1 receptor and anything that attaches it and modulates it, so we have a THC, dronabinol, nabilon listed here just as examples, will block the receptor or will impact the receptor, which will effectively block the neural releases of certain neurotransmitters, including dopamine, norepinephrine, and thus decreasing neuroexcitatory pathways. The pain pathway is a little more complicated. They involve both stress pathways, but also peripheral and central pain pathways. This is understood a little bit less. I say that this is just entering a common understanding. So I'm not necessarily pointing and going into great detail on this slide. Partially, I'm not sure that this is critical clinically. I think the importance here is that we didn't know previously that 2-AG is actually playing the most important role here. In essence, it serves as a brake on the descending pain modulation pathway. So when you have an acute trauma, for example, let's say a car accident, the first thing that's going to happen is that 2-AG gets mobilized and starts to sort of impact immediately the both amygdala, periventricular nucleus of the hypothalamus, and then the serotonergic pathway. So it sort of occurs simultaneously. And this is, of course, one of the targets of the exogenous cannabinoids as well. So a little bit more on the TRP family of receptors, which we now think of them as a CB3 receptors, although again, this is a very fast evolving science. So stay tuned more. But this is an understanding of how that happens on the peripheral pathways. This is the importance here is that notice that the receptors go all the way to the end tissue. So in this case, it's the skin. And so the topical applications of cannabinoids, which has been controversial, I would say, until around 5 years ago, actually is a very profound method. And you will see it, I'm pretty sure, rapidly increasing, not only for dermatologic conditions, such as eczema or pruritus, but also for peripheral pain conditions, particularly things like peripheral neuropathy. Okay, so let's go back to the actual plant. So there's lots of shifts and I think lots of clarifications that has to be made. Those of you who have some sense of the field and understand these terms, as for example, indica and rudialis and sativa, those are all misnomers. They are outdated way of classification, which is going rapidly away, as the science basically tells us that there's only one plant, and all of the cannabis, hemp, everything is basically just cannabis sativa. There are about 20,000 known variants, and they have been known for thousands of years. And the only difference between hemp and cannabis, even genetically, well, genetically they're identical, but it's really just the amount of THC in the plant. And so the importance of this is we are creating the infrastructure here that doesn't actually have a botanical value. And so that's, until that problem gets solved, I think we're going to have a lot of nomenclature and a lot of classification problem ongoing. Of course, it doesn't help that the whole field is still Schedule I controlled substance because the research is still significantly hindered by that. Now, THC and CBD, what we consider are major cannabinoids, and then you have over 100 different active ingredients, and we're going to touch a little bit upon flavonoids, a little more upon terpenes, and we're going to discuss in a minute a little bit more about minor cannabinoids, which we'll take hold now. But before we do that, word on psychoactivity. Again, this is another term that needs clarification. Every single cannabinoid is psychoactive. That includes CBD, that includes CBG, CBN, and all others. Of course, only certain cannabinoids are psychotoxic. That's the right term. So that's the term that describes the high. Previously, we used the term psychoactive to describe the state of high or intoxication. That's actually incorrect. The psychoactivity is simply defined as a central nervous system effect. And probably one of the very few cannabinoids, minor cannabinoids, that doesn't have a clear psychoactivity is the tetracannabinolic acid or precursor of THC in the plant. It doesn't seem to have a definitive affinity at all to CB1 receptor. And that's obviously, you can imagine that this has currently been rapidly explored, not only by medical cannabis industry, but also by the pharmaceutical industry as a good target for peripheral targets. Unfortunately, no matter what cannabinoid or hemp product our patients are taking, they are at risk for having positive tests. So even if they only take CBD for, say, social anxiety, even less than 0.3% THC in the final product that has CBD will be enough for most patients to cause a positive commercial test. Tests are only picking up currently plus minus. There are working on quantitative tests, but at the moment, this creates a lot of legal problems for certain patients. And since I've been testifying on a number of cases, I only take cases of defending patients in this case, or defending clients in this case when they get fired from jobs. I see a lot of really misunderstanding of this whole topic, but we don't really have currently much better commercially available tests. And while high only lasts for a few hours, the THC is going to stay in the system for weeks. So going now a little bit deeper into exogenous cannabinoids, it is critical to know how they made. And the reason for that is if you don't fully understand that THC and CBD are actually byproducts, kind of miss a point that the whole topic is so much more complicated. So the raw material, so this is the actual hemp, cannabis, whatever you look at, is going to have these precursors. So you see this molecule, this letter A. So that stands for acetic acid. And turns out we previously used to think that all these acids are just pathway to get the good stuff. Turns out that they all have very profound medical applications. Research, of course, is just underway, so I don't think we have any clarity except for CBDA, which I'll discuss in a little bit. But they are potentially profoundly applicable to health and medical problems. They have to be activated, so they have to be usually heated, although now there's some chemical process that can activate them and turn them into, of course, THC and CBD as the main ones. And then there are breakdown products. So you will go into delta H THC shortly, and delta H THC, which is a disaster at the moment, can be naturally produced by the plant as it lays there aging, but it also can be synthetically expedited. So all of these errors can be moved faster depending on a chemical process. And I'm not an expert in any of that. All I know is that the pathways of making these molecules are now commercially available at very large amounts. So the prices of all these molecules have been going down pretty quickly. So some of the newer cannabinoids. So CBG, we're going to talk about that, cannabigerol, CBDA and THCA, accordingly, the acidic forms of CBD and THC, cannabinol, which is now promoted heavily for sleep. And then, of course, this whole mess with the delta H THC, tetrahydrocannabinol. So let's take a look at one at a time. CBG is something that I feel will have a useful application in upcoming years. It has a quite weakened partial CB1 and CB2 receptor activation effects. In animal studies, it shows neuroprotective, anti-inflammatory, and interestingly, a pretty potent agonistic effect on serotonergic pathways. And there's multiple studies on the way to co-administer CBG with SSRIs. It also has some antimicrobial property, although this is not well understood. It is made from hemp in the industry, so people can just buy it, have it shipped to their house. They don't need to have medical card to get this. none of the claims currently supported. My interest in this molecule has been from a small animal studies in rats showing that it's a very potent appetite stimulant, probably from serotonergic pathway, although I'm not fully clear on that. So there is an interest in looking into this molecule at the high doses as an appetite stimulation in frail older adults and in patients with cancer, but there is no actual human data on this. CBDA, if you were to remember one molecule out of everything I said in a good way, so this is good, I remember this one because I actually think that this is rapidly gaining traction and there is some good data accumulated. It's a very interesting molecule. It's very similar to CBD except for the acidic form, and you would expect the same problems as CBD. So CBD is a pretty potent cytochrome P450 both activator and for some enzymes suppressant. So you definitely anticipating CBD to drug interactions. It's not so with CBD. There's a lot less impact on that. And it's also very profound blocking of COX-2 without observable side effects of that blockades. And this is where I think the major therapeutic impact of CBDA is going to lie. So the rest of the other anti-convulsant and anti-carcinogenic, I don't think that's going to come that critical, especially since now we already have the CBD as a FDA-approved seizure medications. I'm pretty sure over time that's going to expand to other types of seizures. But this is pretty unique, and especially since for our older adults, we really try to keep them away from the NSAIDs or anybody who has gastric ulcers or problems with increased risk of NSAID toxicity or side effects. The CBDA may be a really interesting alternative. So in practical, the way I use it is for any inflammatory arthritic conditions, whether it's osteoarthritis, rheumatoid arthritis, I'd start pretty low and then I pretty quickly accelerate to dose. And again, commercially, 2 or 3 years ago, this would have been 100 milligrams a day, would have probably cost patients upwards of $200. Now the price has dropped to under $100. It's still a lot, relatively speaking, but if you compare that to opioids or some of the other, it's definitely biologics, for example, it's just the problem that the patient's paying out of pocket and it's not covered by any insurance. THCA, I did started mentioning that it interestingly is not found in the brain. It's not really clear whether this is because there is no CB1 activity or that it simply does not lock, that it just doesn't cross the blood-brain barrier. It's not very clear yet. There's a lot of animal data showing a pretty similar to THC impact without psychotoxicity. So you cannot really get high on the THCA. It's not as widely available in hemp market. It's not really clear why. I would say the potential of this molecule is pretty good, but some of the commercial, I'm guessing it's have more to do with the cost of making it. Before the summer of 2021, when Virginia approved THC finally, this was the main molecule that was sold in the dispensaries, and there was a lot of confusion. Even some of you attending this call, this Zoom, have asked me this, like, well, patients can get THC. No, they could not have gotten THC until this summer. They were getting THCA, and THCA for pain actually has a much lesser analgesic effect and actually not commonly used at all. CBN, you may have heard about this because it's heavily inappropriately advertised as a cure for insomnia. It is not a cure for insomnia. There's really data is very mixed and at best inconclusive, and actually probably may pan out to be not effective, with one exception. I think when it does work, when it's combined with a small dose of THC. And this will bring us in a few slides to this whole aspect of entourage effect when different cannabinoids interact between themselves to enhance the clinical effect. We're only at the beginning of understanding of entourage effect, but what we have known for decades is that when you try to isolate these compounds and then you apply them, quite often the effect that the patients would say, well, I smoked this, well, not supposed to say strain anymore. So I would smoke this variant. Well, that sounds weird, but that's what we're supposed to say. I will smoke this particular product and it works for my sleep. But if I smoke that one, it doesn't at all. So that's, even though the major cannabinoids may be identical there, but then there would be something like CBN in one and not in another, and that would make a difference. So when they try to isolate it, it doesn't seem to pan out as well. And that's a repetitive topic and repetitive theme that occurs over and over again. And this is why I'm going to just do a little diversion here for a second. This is why I actually think this is one of few topics, and this is why I'm particularly interested in it, where the botanicals and integrative medicine will coexist pretty happily with the pharma, because the pharma is going to do what they're going to do, but they're not going to be able to capture the entourage effect, because it's basically impossible. You're looking at the 100 molecules and figuring out their interactions will take decades. And even if somebody does figure it out, chances are that commercially speaking, it's going to be way more complicated to make rather than do full extracts of the full plant. All right, let's turn to ugly. So this is really ugly. Those of you who have teenagers, you have to know about this, because if you have a teenager, they can simply go on the weed.com, purchase whatever they want, have it shipped to their house, to your house. And the impact of it is very similar to Delta-9. So literally, this is a legal high sold in every state without any control by any state governments. I'll show you how crazy it gets in just a second, just on an example. And it is mostly used recreationally. No one knows what the medical value of this product is, even though patients claim it works very similar. There is zero data. There's no animal data either. So it's all not just wild, wild west. It's way worse than that, because as you'll see from this, so the public interest literally increased so much that it outpaces any legal capacity to control this, because the public interest grows so fast that certain states just now starting to say, wait a second, how do we deal with this? It is sold as a hemp. It clearly should be Schedule I controlled substance, because it's just, it's maybe 2-3 times less potent as milligram per milligram as THC. But if somebody buys 10 milligrams instead of 5 and they get exactly the same impact as Delta-9 THC, wait a second, why would anybody then buy Delta-9 THC if you need to have a recommendation? And it's also a lot cheaper. So that's a huge problem. So this is me walking into Shepherdstown, just a couple of miles from Harper's Ferry, going to a restaurant to eat with my family right after day after Christmas. And next to the restaurant we were buying, there's this shop. So I walk in just to say hi, and then there's this. So what you're seeing on this slide, there's not a word that there's no child protective cover. There is no word that this is toxic substance, or psychotoxic. There's nothing there. It's called giraffe nuts. There's no label here that it's people under 21 should not be used, because of clear evidence that Delta-9 has a negative impact on brain development. So it's pretty crazy. And you just buy it for, I think this was $30 for 8 chews. Each one of them, I think, is 25 milligrams of 10 chews. So 25 milligrams, if you're naive and you've never taken this and you take this, you'll be high for about 8 to 10 hours. You wouldn't know where left or right is, potentially, especially if you're a sensitive individual. This is a little bit better. I didn't buy this, my friend did, but you see that this at least has 21 keep out. It has a clear label, says that, there is no Delta-9 THC here. And they sort of say that, okay, this may have some clinical application. I'm not going to go there with the Delta-8, but, so it's basically all over the place. I'll give you another sample story. I had a call from a few weeks ago from a friend of mine who basically said that their 14-year-old is getting kicked out of school because they caught him vaping Delta-8. And when they're asking where'd you get this? He said, oh, I just bought it online and had it shipped to my house for a few dollars. And so this is left and right. If you have teenager at home and you have not had this conversation with them, please do. I think it's critical that you understand that expected dangers of Delta-8 are going to be identical plus some more, as I'll show next slide. Basically, the worse brain development, potential increased risk of schizophrenia and paranoia-related illnesses, and just a poor cognitive outcomes later in life. The early exposure to THC, when anandamide peaks in an endogenous in around the age of 12 to 14, if at that time the brain starts seeing exogenous THC, it suppresses normal anandamide development with a pretty catastrophic long-term brain development impacts. And so I've been very vocal to say that this age should really get bumped up to 25, because that's, we have a little bit of evidence to say that after 25, exogenous cannabinoids appear to be a lot safer and don't really have that significant potential for long-term side effects. So another big concern is literally the how it's stuff made. Notice that extraction process has to use acidic acid catalysts, and they end up in the products, and there's a good evidence for that. Nobody knows what the long-term consequences of taking this stuff chronically will be, but I wouldn't want my kids or anybody else for that matter to be exposed to heavy metals. So a couple more words on entourage effect, because I think you have to really know this term. So it's basically when all of these active ingredients come together. And entourage effect is not only necessarily something that enhances the efficacy, it also seems to decrease side effects of pure THC. What I mean by that, those of you who like or who have used dronabinol or marinol in practice know very well that it's not very well received by a lot of patients. While it can be quite effective for nausea and vomiting, it's a lousy tool for pain. If you were to give your patients a choice between those who experience, between marinol, dronabinol, and medical cannabis, it's very unlikely that they're going to pick dronabinol no matter what the copays are. And I've seen this again and again in the practice. Terpenes are really important to keep in mind. They are the smell molecules, literally. They can be categorized from calming to energizing effect. And so the interest in research currently is quite significant. What happens if you take, say, THC with a certain amount of milligram per dose, and then add, for example, myrcene? So in the past, if you add myrcene and pinene to a THC and you put it in a tincture, this would be called an indica. And then for something like limonene or caryophyllene will be a sativa potentially, so kind of more energizing. That's all going out of favor because really, it's really the terpenes that make this effect, and we need to be naming them. There's an attempt at creating classification of products based on this. So if I give an update in a few years, I'll probably talk more about it. Okay, let's go back to the old data now. In 2017, in the world of medical cannabis is ancient. Things shift so quickly, I can't keep up. My book that just came out 2 months ago is already feels outdated. I'm not kidding. So 2017, NAS published this very extensive report. I still think it's the best summary of evidence we have, even though there's been new updates since. But this analyzed upwards of 80,000 publications. And their conclusions were that there's basically grade A evidence for use of cannabis for chronic pain in adults, as an antiemetic for chemotherapy-induced nausea and vomiting, and also for improvement of multiple spasticity in MS, spasticity in multiple sclerosis. Some of the evidence for insomnia, I would say, starting to move from moderate to conclusive, and I'll show you in a second a little bit more, and we're also going to talk about the case. I also would say that fibromyalgia is starting to approach conclusive evidence as a newer data, but some of the data is not changing. So the increase in appetite probably actually dropping to no evidence. So if the products, we used to think that THC is a good appetite enhancer, that is not turning out to be the case, unfortunately. And but things like autism and Tourette syndrome, there's a reason why Sanjay Gupta went after that topic, because there is a growing evidence. I'm not going to discuss that because it's mostly pediatric, and also I don't really think there's enough data there. But this is what post 2017 that I would say reasonably strong, that I can put my head and say there's enough evidence to support the utilization. I'm not going to discuss further about Epidiolex. I did talk a little bit about this on 2019. I will tell you just a couple of things. So one, it is a pure CBD, so there is no anti-rash effect. They purified, it's what's called an isolate. It's just the CBD. It's only approved by FDA for certain types of pediatric seizures. And although there are studies for general adult seizures, I don't expect them to come out in the next couple of years. It's going to take a bit longer. Interestingly, there are two things that are important to know. The collective data on kids taking high dose CBD, and we're talking about upwards of 1,000 milligrams a day, we're not seeing as much CBD drug interactions. It's very unclear why. We should have expected to see them by now. We don't. There's been some thinking that maybe actual interactions in a clinical realm are less. On my anecdotal evidence, I've seen few patients overdose on opioids, but those were older adults. They were not kids. So maybe part of the issue is that when CBD is given to kids in combination with seizure meds, their interactions are not as severe as in adult population. But I think it's an interesting topic for further research. I would say that the general use of CBD for anxiety at this point is reasonably supported. It's a good indication to try. The doses don't need to be high. Adjunct use in schizophrenia for behavioral problems for neuropsychiatric symptoms is growing rapidly. Not my area of expertise, but the data is there. And also fascinatingly, the topical CBD particularly seems to have a pretty quickly growing dermatologic data. It's not quite there yet, but there's a handful of companies that are isolating CBD and trying that topically so stay tuned. THC, Canada has improved THC for use of neuropsychiatric symptoms in Alzheimer's because it's not only way cheaper for them, but it's also way safer. So as you know, that any tranquilizers are not to be used because they increase mortality. It turns out THC does not. And so there are countries that are switching because of that. So this is quite evidenced at this point. PTSD is question mark because there's a very high interest, especially in the veteran population. The studies are mixed. There are a few good studies showing certain types of symptoms, that PTSD-related symptoms, particularly insomnia, can have a dramatic benefit from THC. So that's why it's there. But I wouldn't say that it's a standalone treatment. Fibromyalgia also quickly increasing data supporting use. Interestingly, with fibromyalgia, doses of THC that are seemingly required to control the symptoms of mostly pain seem to be a lot higher. For chronic pruritus, it's more of a systemic THC versus topical CBD is more for localized pruritic conditions, like an acne, or well, acne is not quite pruritic, but let's say localized eczema can be quite pruritic. And then one of my currently most favorite reasons to use THC in low doses in combination with CBD and in CBN is really the insomnia. And the data for that is very rapidly increasing. I just reviewed a paper a couple of weeks ago, basically showing that in Colorado, amount of over-the-counter drugs, like Benadryl, for example, used to self-medicate insomnia went down 50% in the last 5 years, about 10% a year. So it basically parallels what we're seeing in terms of opioid use in the states that have legalized medical or recreational cannabis. We're seeing a similar 5 to 10% a year drop of use of opioids, and then also opioid-induced mortality. But this topic I covered 2 years ago, so I'm not gonna show you that data. So here's a case. My own patient referred, I think about Dr. Jane, I believe, or maybe self-referred, don't remember. So he was seen by everybody. He has this really severe night terrors, came on multiple medications. He also has bipolar disease, tried all kinds of things. He himself wanted to try cannabis, so this was not a difficult conversation here. And the product that he was started on, it's a pretty typical, I still use word indica here because the case was about 4 or 5 years ago when we still use that term heavily. This is the typical protocol. So I would start with somewhere between 1 to 3 milligrams. It's extremely low dose with a full extract oil under the tongue. and then gradually titrate the dose upwards of about 10 milligrams or whatever the first effective dose. So in about 4 weeks, he had a complete resolution of symptoms with complete normalization of sleep. Effective dose 6 milligrams. Now, about 3 years later, he's somewhere between 8 to 10 milligrams, but holding. I'm not going to go into tolerance much, except to say that there is some of that, but when the dose is used steadily in a more pharmacological ways, that tolerance seems to be minimal. So that's one case. And then another case is a demonstration how I use it in advanced Alzheimer's in patients who start to get a lot of behavioral problems. So this is actually a mother of our massage therapists that are at CIM. And we started talking about this whole, she would live in Virginia, so I'm not even going to go there. This was some years ago. So the staff actually, this is a unique challenge. So this at that time, giving her THC was a federal offense. Son wanted to do it because they felt that they didn't want to give her tranquilizers. She was about to get kicked out from the group home into a nursing home, and he wouldn't be able to afford it. So this was a pretty, for the son on the limit massage therapist income, this would have been a pretty dramatic problem if she would have had to move to a much more expensive facility. So frozen yogurt of CBD twice a day, and then brownies at night. Notice this is not somebody who I could give a drops under the tongue, would refuse to take. So had to improvise and make the products palatable. And that's one of the huge benefits of cannabis. You can take an original oil and then hide it or mix it with any foods. It can be applied in so many different ways and prepared in so many different ways and in so many different doses that it makes it very patient friendly. So she had a pretty complete normalization of her sleep cycle, and the whole screaming at night went away, and then she died peacefully a year later in the same facility. So, and that brings me to kind of the way I use cannabis in my practice. I would say that more than half of all of it I use in palliative medicine. I believe it's the best tool we have. It's not, of course, the only tool, but it's the only tool I can think of that can simultaneously improve patients' quality of life and then treat multiple problems: nausea, vomiting, pain, sleep. So if the patient has advanced cancer with or without chemotherapy, that this seems like a one tool that can hit so many different targets, and then the main side effects is being euphoric. And I'm yet to see a single cancer patient in their last 6 months who would tell me that they consider euphoria a side effect. So, I just want to put a plug for cannabis here. And I do think that, unfortunately, this is underutilized and under-investigated topic to the point where just recently I published an article talking about this. So moving a little bit to some of the side effects, the CHS, or cannabis hyperemesis syndrome, or cyclic vomiting, as it's often called, is really a rapidly growing concern, especially in the states that legalize recreational use. We don't see it as much with medical, probably because combination of THC with CBD seemingly blocking this condition from ever existing. But it's the patients who use THC in high doses recreationally who end up in ER, and often it goes undiagnosed for a long time. So I think we do have to help our ER colleagues with this. I wish that there would be more particular ways of diagnosing this, but there isn't. It's really a clinical suspicion. There's no tests. Just doing a drug screen and saying that somebody has positive cannabis in their THC in their urine, that doesn't really help you much. Unfortunately, the best treatment is just not taking it. It's even makes it worse, the fact that often patients will tell you, well, if I use THC, I feel better. But then a couple hours later, the vomiting the cycle begins again. So they will smoke again, they'll feel better for a little bit, then worse again. So they're sort of self-perpetuating this cycle. The real better treatments are hot showers and then potentially capsaicin cream on the abdomen. This is the fact that TRPV1 receptor can be effectively activated by capsaicin blocking some of the negative THC impact. And then there's a good experience with low dose Haldol between 1 to 3 milligrams as a supportive treatment. Now, staying on this acute side effect topic, there is a good recent understanding that some of the terpenes added either isolated from cannabinoids or just as a food, literally a lemon water, squeezed lemon the morning after, if the person is still having hangover-like feeling from taking too much THC, quite often can address that. Interestingly, notice that the acute impacts can be both. People can be lethargic, but they can also be insomniac, depending on the type of product is taken, the route of administration, etc. So just tells you how complex the interactions are. Okay, and then I want to finish the last couple of minutes with this topic of, I think that's essential that we as a faculty beginning to get involved in the medical cannabis education. And there's no doubt in my mind, and probably in everybody's mind, that we're somewhere between 5 to 10 years away from descheduling or rescheduling of cannabis. So this is going to further move the amount of medical cannabis used by our patients. So we have to start teaching our students. Currently, unfortunately, most of this is our article published in 2020 in Complementary Therapies in Medicine. We did assessments of our own students in GWU, showing that pretty much everybody saying we don't learn anything and we really want to learn because patients ask us. And that's very consistent with international experience. This is an article we just published last year on scoping review of all the existing international healthcare trainees' opinion and the assessment of existing programs. And basically, it just underlines the same thing, that most of the countries do not have any competencies-based curricula, and essentially whatever it does exist seems to be very fragmented and not standardized. So some of the things that are currently going on our campus, Dr. Borum is interested in observational assessment of IBD. I'm interested in observational assessment of Alzheimer's disease. We just got a grant, small grant, to do a Delphi process. And we already have a pretty good number of experts. We're aiming for about 25. We have Dean of Ben-Gurion Medical School and University of Chicago, hoping to get a couple more people. So if anybody's very interested in curricular development and want to join us, by all means. And Dr. Friedman is quite interested in topical CBD, both as a hemp produced, but also as a pharmaceutical CBD. So really, is cannabis ready for mainstream medicine? This is Dr. Ethan Russo, is probably one of the most significant current experts on this general topic of research in medical cannabis. And he basically says that, is there a pathway that will lead to the return of cannabis to, notice the word return, to mainstream medicine? The answer is clear in as much as it's already commenced. It follows the same time-honored process that any pharmaceutical must attain to receive regulatory approval, proof of biochemical uniformity and stability, along with safety and efficacy, as proven by randomized clinical trials. And so in conclusion, it's definitely proven, I would say, for chronic pain. Now, what's not really clear as to exactly what are the best preparations, I have spared you some of the internal struggles and the fact that there's an industry push to say that CBD works for pain when there's not a lot of evidence for that. So it's still an immature field, but the overall data on THC for pain appears to be pretty strong. This is my opinion, that I think is supported enough by evidence that it's one of the best palliative tools we have. The ugly aspect of the industry is that the claims are carriage is so ahead of the horse that you don't even know how to turn that around. This exuberant claims going to continue. What to do with our kids' growing population and the success to delta H THC that increasing something like tenfold every couple of months in terms of use, not very clear. It has to be regulated. And the climate, the legislative climate is moving, but of course, COVID slowed it down, and it is moving, I think, overall in the right direction. I think there is a massive decriminalization, and I didn't get to really discuss this whole racial concerns within this field, which is still quite a big concern, but it's getting better. And rescheduling will dramatically move speed of the research forward. If anybody's interested in additional training, I'm involved in this. I'm not teaching this course, but I have developed one of their modules, and I do sit on their curricular committee trying to improve the components of teaching. And here are some of the resources. Best patient resource commercial is Leafly or Leafly. And then I like the Normal. Normal gives people very clear instructions how to get cards, and also a lot of information regarding logistics of each state. Project CBD is an excellent nonprofit resource, not just about CBD, but about everything. And then these are more of a clinician-based nonprofit resources that I'm gonna leave there. And I hope that the reason the book was written, that I really hoped that I got inundated with same questions by my patients. I said, I'm just gonna write it. So the way this works for me now, I write the recommendation. I tell patients, go buy my book, read particular chapter or the whole thing, get a couple of basic starting points. 8 weeks later, come back when you already have a card, and then we'll create the regimen. So with that, I'll leave the slide here, or maybe we need to put the slide for the CME number, and we have 5 minutes for questions.
Great. Well, Misha, thank you for a wonderful talk and an update from your talk a couple of years ago. Clearly, the field has advanced and changed quite a bit in terms of the data in these 2 years. And I appreciate you helping us to make some sense out of, a complex set of chemicals and how they relate and how they're used by our patients. And I appreciate it as well, bringing the science to what is known here. I'm going to, in the interest of time, jump to the questions in the chat because there's some great ones there. Dr. Stone asked, does sleep quality improve or just subjective reports of sleep improvement? Right.
So it's very interesting. Low dose, when it hits effectively, it actually improves cycling of sleep. There is a data to show that actually the sleep architecture even improves, not just the total amount of sleep, and the recovery scores are improving. So yes, but it's easy to overdose. So at the higher doses, THC actually starts disrupting the sleep. So it's kind of a J curve, if you will, and that needs to be carefully counseled to the patients. And it's not very well understood out there, and a lot of dispensers have no idea about it. And that causes all kinds of mess. I mean, it's common for me to have a patient come back and say, oh, I just went to the dispenser, they gave me some edible, and it's like 10 milligram edible for somebody who never took THC. And then they're tripping all night. They're not sleeping at all, even though they took it for the sleep. So it's correct to assume that it's more complicated, and it's easy to actually overdose and cause more sleep disturbances. So again, that's why the data is mixed. And when you look at the careful titration protocols, they seem to be quite effective.
Great, thank you. And a question from Dr. Jays. He says, the small excess mortality of antipsychotic agents for the treatment of dementia and behavioral disturbances was discovered from databases with hundreds of thousands of patients. Are the data for the safety of THC nearly as robust? And may we someday learn of an excess mortality of that substance with more data available?
Yeah, I mean, I think it's a great point. This is all, we're entering the topic, right? So we don't know what we'll collect in terms of data in the future. But I will say one thing, that we don't even know what THC lethal dose 50 is, meaning it's not really clear how much THC somebody has to swallow to die. They've tried to do this back in the day with monkeys, and they couldn't figure it out. So you can take insanely high dose and just slip it off and have, horrible psychotoxic effect for hours, but not seemingly have any problems unless you walk out of the window or end up in some kind of accident. So Bob, I don't know. We don't have an answer to this question, but I would say that, at least in contrast to, say, our commonly used Haldol or atypicals, it's probably is safer, and I think it will stay that way data-wise.
And Dr. Corona asked, please comment on potentially detrimental cognitive effects, especially in younger patients, and the risk of permanent psychosis in vulnerable patients.
Right. So my next project, I'm trying to take it off the ground, is to write a book for teenagers and kids, because this is a huge problem. In a way, it's a bigger problem than alcohol. Why? Well, because I think with alcohol, there is at least some clarity and people are pretty clear, don't give alcohol to kids. With Delta 8, I mean, that place where I went to in Shepherdstown, I start talking to this, and she's, oh yeah, 12-year-olds can take it, it's safe for her, for him. Like, there's just such a mess of not knowing and such a profound, easy access at low cost, and we will see serious long-term problems. There's no question about it. It's not just detrimental for increased risk of schizophrenia, and data is very clear on that. The effect on cognitive is being done over the years using fMRIs, showing a very clear underdevelopment of certain parts of the brain, particularly hippocampus and hypothalamus. So, you know, we do know there's negative impacts. They're undeniable. There is some thinking that CBD blocks that, but there's not enough data to say, oh, you know, just have all the kids to take CBD. But that's what I often tell to the parents who tell me, look, I can't control this, which it happens all the time. And I'm at the age where a lot of my friends have kids in sort of 12 to 15 to 20 range. So I've been lately inundated with phone calls saying, oh, you know, he overdosed again. What do I do? So sometimes I talk to those kids and I say, well, at least take some CBD if I know you're not going to listen to me. But it's not a foolproof in terms of blocking the negative impact. So that's why I think it has to be regulated, tighter than it's now. I think that hopefully it will happen.
Well, thank you, Dr. Kogan, for a wonderful talk, for educating us all. And congratulations on your new book and all your important ongoing work. So thank you everyone for joining. Stay safe out there and have a good afternoon. Bye-bye now.
Bye.